Hello, everybody. I'm Allison Ramsey. I am an allergy immunology physician at Rochester Regional Health in Rochester, New York. I am the current chair of the Quad AI's Adverse Reactions to Drugs, Biologics, and Latex Committee, and I'm also head of the Penicillin Allergy Work Group for the Quad AI. In this video, I hope to update you on some important developments in the field of penicillin allergy. So we all understand why penicillin allergy and an unverified penicillin allergy label is an important thing to address in our patients. So it has a prevalence of around 10% of outpatients, and it has been shown to be as high as 15 to 20% in the inpatient population. An unverified penicillin allergy label has been linked to an increased length of stay, increased costs for medical care, increased antimicrobial resistance, and in a big study of many patients, it has been linked to an increased risk of all-cause mortality. The updates I want to share on this video include the improvement that patients who have a low-risk reaction history may be able to undergo a direct oral challenge. I want to touch upon how we risk stratify these patients, discuss how we can harness telemedicine and e-consults for penicillin allergy evaluations, and then discuss penicillin allergy evaluations in some special patient groups. So penicillin allergy has received a lot of attention over the last few years, given its adverse effects and implications that I briefly touched on. So it's difficult to skin test all of these patients, and historically, that's what was done. So patients underwent prick testing to penicillin G, pre-pen, perhaps a minor determinant, with intradermal testing after, followed by a challenge to usually amoxicillin to delabel their penicillin allergy. As penicillin allergy evaluations have gained more traction, there is a lot of data supporting the use of direct oral challenges. And so patients who receive test doses of penicillin followed by a full dose without preceding skin testing. So there was even recently a randomized trial that looked at low-risk patients undergoing skin testing and low-risk patients undergoing direct oral challenges. And this trial showed that skin testing may overcall penicillin allergy and direct challenges may save a little time and also may save money. So how do we risk stratify these patients to undergo direct oral challenges? There's a really nice body of data supporting direct oral challenges, and how to risk stratify patients varies depending on which center has done the study. So there are various published models, but in general, patients with a low risk reaction history have a non-immediate cutaneous only reaction. And the time elapsed since the reaction, again, depends on the center, but it's anywhere from 1 year to 5 years. A more conservative study was even more than 10 years, but in general, somewhere between 1 and 5 years has been accepted. Patients with an unknown reaction history have also been lumped into this low risk category. Certainly, penicillin skin testing is still indicated in any patients who have a history suggestive of anaphylaxis. So anybody with respiratory symptoms or cardiovascular symptoms or significant angioedema. Certainly when there's more than just mild skin symptoms involved, these patients still undergo skin testing. And of course, patients who have a reaction history that's suggestive of a severe cutaneous adverse reaction or some other adverse reaction that's concerning should be told to continue to avoid penicillins. So we've all become more familiar with telemedicine during the COVID pandemic. And there are a number of studies that have shown how to use telemedicine and also e-consults to further penicillin allergy evaluations. So With telemedicine evaluations, most drug allergy patients, and specifically penicillin allergy patients, will still need to present for an in-person appointment for either a challenge or for skin testing, depending on the risk stratification. But the body of data looking at drug and penicillin allergy with evaluations with telemedicine have shown that a minority of patients may actually be able to be delabeled without an in-person evaluation. So the low-hanging fruit patients who, for example, have a family history of penicillin allergy and they're avoiding based on that, or if they have symptoms suggestive of an intolerance, those patients can be delabeled just through a telemedicine visit. If patients do need an in-person visit, the telemedicine evaluation still allows the practitioner to decide, is this person a patient, a candidate for an oral challenge, or do I need to have skin testing materials available when they present for their in-person visit? E-consults have also emerged as a way to partner penicillin allergy evaluations and oral challenges. There's some data on the inpatient side using an e-consult, which can be thought of as a little bit more formal than a curbside consult, but less formal than an in-person consult. So this is where a practitioner uses the information in the electronic health record and makes recommendations based on that. So there is some data on the inpatient side where patients were evaluated via e-consult and underwent oral challenges while in the hospital, while the allergy immunology practitioner was seeing outpatients. So this can be time saving on both the inpatient side and also for the practicing allergist. And lastly, I wanted to update on some special populations that can benefit from penicillin allergy evaluations. So a big group is the oncology group, where there is data showing that skin testing and maybe even oral challenges in low-risk patients improve the use of first-line antibiotics in the oncology population, decrease their costs associated with treating infections, and decrease their days of antibiotic therapy. There's also data that's emerged in the obstetric population. So 20% of pregnant women are colonized with group B strep, and penicillin is first-line therapy for prophylaxis surrounding labor and delivery to protect the neonate from group B strep infection. There are a number of centers that have published data on the safety of skin testing in pregnant women to delabel penicillin allergy, and the majority of these women are delabeled. There's also emerging data, small studies so far, on some direct challenges in this group. Evaluating obstetric patients for their unverified penicillin allergy has been shown to reduce their need for broad spectrum antibiotics or less effective second-line therapies surrounding labor and delivery. There's also data showing the educational initiatives surrounding penicillin allergy and appropriate use of beta-lactam antibiotics for pre-surgical prophylaxis are effective. So educating the anesthesia and surgery about the ability to use cephalosporins despite an unverified penicillin allergy label has improved the use of beta-lactam antibiotics preoperatively. And there are some institutional initiatives that have these patients undergo penicillin allergy evaluations prior to their surgery. The Quad AI is committed to promoting this aspect of our field. Please spend time on our website. There's a penicillin allergy toolbox that can give you the references for all of these important updates. And thank you for listening.